So welcome everyone. I'm very pleased to introduce Dr. Mobin Master. He is an aesthetic radiologist from Melbourne. He has combined his two specialties of aesthetics and radiology to shed a little bit of light, a lot of light, I think, on the reality of what's happening with our dermal fillers in the long term. He has just been accepted for his groundbreaking solo author peer-reviewed publication, which, sorry, I've missed the title of. So MRI evaluation of hyaluronic acid dermal fillers just been accepted by PRS, so you'll be able to get hold of that publication soon. And also I discovered, if you Google Dr. Mobin Master, that he's also a talented musician with his own music video, which I thought was a really cool little backstory. So multi-talented, and I'm really grateful to have you on. Thank you very much, Dr. Master.
Thank you. Dr. Pierce, you can call me Mobin. That's fine.
Mobin.
I'll call you Tim. All good.
I like Dr. Master.
I'm actually a big fan of yourself. I realize that I've been listening to your podcasts.
Oh, great. That's really great to hear. I'm always amazed how far those reach. So yeah, it's great to meet you in person. Obviously I saw you on a YouTube video first. That one did really well. Is it Dr. Gavin?
Gavin Chan.
Yeah. So right. we all were very intrigued by that. And then someone else was sharing something else that you wrote about recently. And the interesting thing about what you've discovered and proven is that this is why I really wanted to have you on, is I fundamentally think it changes what you have to do in the practice. There's a lot of things you can do to make yourself better and, understand things better, but this is a real practical shift in how we manage patients in the long run. And if you're going to do aesthetics for 6 months, you probably don't need to worry about it. But if you're going to do it in the long term, like most of anyone worth their salt, this is really vitally important. So this is why I'm so pleased that you're on with us today. I was looking through your website and also seeing that you're not just using MRI, but you're also doing some work with ultrasound guidance. And I was wondering if we could start just by discussing what other imaging you're using and how you're finding that useful in aesthetics.
I think MR and ultrasound are the primary two modalities that I would suggest aesthetic physicians should use. An MRI does take a bit of time and it seems like a bit over the top, but when you're dealing with long-term complications and issues, and if it's an overall snapshot of the face, I've created a protocol that only takes about 22 minutes and it should be relatively cost effective, even though it's out of pocket. And that's part of the article that's going to be published on PRS, to give a practical approach, because there's a lot of discussion on, MRI, this is too medical, this is not in the aesthetic arena. It's also very useful, obviously, for my research, and I've been using it predominantly for research. Ultrasound is more practical, where I feel in about 5 up to no more than 10 years, I think almost every aesthetic physician will have a scanner in their rooms. I think it is the future, and it increases safety, but obviously ultrasound takes time you don't learn aesthetics in one day, do you? Mm-hmm. So it's the same kind of concept. I've actually thought about buying an ultrasound machine myself. There are obviously different standards you can get, and they're pretty expensive. But right. I was thinking, when you learn about anatomy, you get this average picture in your head of what the average face should look like, and you apply that to each patient that you see, and then you go and do a dissection lab, once a year, and you discover that it doesn't match, and sometimes it's horribly different. And this is what you have the benefit with if you get ultrasound your patients, even if you just ultrasounded them once and then stored some information about them, it might give you some extra safety advice. So I was just wondering, can you tell us a little bit about the kind of examples where you've used ultrasound and it's changed your practice? With regards to injecting?
With regards to injecting.
I'm using it for dissolving. With regards to injecting, for example, the chin area in the midline. You know that sometimes there's an anomaly or a variation where you do have a branch of the mental artery, the submandibular artery. When you scan it, I don't think you'd ever inject the chin again because you look at it and you see all these vessels all over the shop. You just think, I don't want to inject this area. So I've used it in cases, for example, midline chin on a lot of patients. I scan there and make sure there's no major vessel there. I do also, which is the Allergan and the the MD code area C5. This area has got a lot of vessels. You've got the inferior labial, superior labial, obviously just lateral to the commissure. You've got a submandibular artery. You could have a branch of the mental artery. So I feel that this area is quite a high risk area. So if I'm going to do a jawline, for example, I would scan here and just see the volume or number of vessels in the area and what their depths are. If there are too many, then I'll start at a different place, or I'll just try to avoid the area altogether.
So yeah, that's really interesting. I've seen it said on forums, "Oh, chin is safe as long as you inject appropriately. It's not a high risk area." But my experience is I've seen multiple occlusions now. We've had one in our clinic. In fact, it happened while I was doing a live show. One of the doctors came in and we had an occlusion that happened right in the clinic, and it's really useful for you to hear that, because there's a difference between these stories that get passed around and reality. And what you're doing with an ultrasound is you can confront reality each time you inject, which is really interesting. It would be great to see some of those images. I don't know do you have any, you may not have any of that specific anecdote or
Not
story,
that
but
specific one. I don't have copies of that. I've kind
it
of
would be, it'd be great. Maybe if you next time you do one, if you put
I'll
on
do
your
an ultrasound
Instagram,
session.
and that would be so cool to actually see that in reality, because I think this area is downplayed. And you've just said, and what I love about you might pick up from how we've promoted you is these shifts in understanding. So I just love that sense that you were wrong and now you understand something more. So that's really useful to understand. And I will say to anyone listening that this risk of occlusions in the chin is definitely there. I've had 3, which is higher. I've never seen, for example, a temple. I've never seen a cheek in personally being sent to, but chins I've seen 3. So it's a high risk area. And that's really useful to understand that the anatomy is different to how we sometimes imagine it. So you're scanning some patients before a procedure, but you're also using this specifically to resolve certain complications. Can you tell us a bit about how you're using this for complications?
So with regards to dissolve, I don't know whether you know of the crew. They're called Cutaneous in Rotterdam, and there's a aesthetic physician who works with some radiologists, who had a technique that I went through with Stefania Roberts from Australia, who's a well-known aesthetic physician. Went through the technique that they use, which is using a very finite small dose adjacent to the spasmodic vessel. So what actually happens, and this is, again, I don't think we understand whether it's necessary occlusion or vasospasm. So this occlusion in the chin, the lips were going blue, and this whole area, the chin was starting to get a little bit dusky. It was early days still. We got an ultrasound scanner on there, and we found that the inferior labial artery was turbulent. So that means that the vessel had to and fro. It was upset. So for example, your carotid arteries, it's like any kind of stenosis, any vascular stenosis where a vessel is getting blocked. Proximal, or just before the vessel occlusion, you will see this turbulence. And what happens is on ultrasound, you see this color, all this color phasing all over the shop. So I followed that vessel down, and supposedly you should see a little bit of stray filler, and that's the culprit. I don't think I could see the stray filler. So what I did is, it only required about 50 or 60 units, but in these situations, you've got the brown pants phenomenon and you just want to get rid of it. I used a few hundred units, but basically, the color came back immediately. It was unbelievable. A bunch of experts gave their opinion on that occlusion. Some of them had dissolve of 1,500 units all the way around the chin, all up here, all along here, literally next to facial artery. 1,500 units, and she would have had to dissolve the whole thing and start again. In this situation, it resolved. 4 days later, she was perfectly normal, and that one dissolve resolved it, and she maintained that jawline, which is amazing. A fantastic result.
So let me just make sure I've got this right. Your patient presents, she's got some dusky, like you can see the blood supply is not right. There's some sort of cyanotic around the mouth. You scan her and you find some turbulence in the vessel at one point, but there's still blood flow, but it's turbulent.
Correct.
That's really interesting. And I'm wondering, I wonder if that turbulence is involved somehow in the vasoconstriction, or if it's well, is it cause and effect? Are you seeing turbulence and that's causing the vasoconstriction? Because, and is the filler, you said you couldn't see the filler. You weren't sure whether it was inside the
No,
vessel or outside the vessel.
that's right. That's
You
right.
didn't,
It was very hard to see. Look,
you
if you can
place,
find the stray filler, that's ideal. If you can find that stray little blob of filler, and ultrasound can look like, when you first start, it just looks like snow.
Mhm.
It takes a while to get used to. It's taken me about 10 years. But I feel that there's a couple of hypotheses that you can use. One is it from vasospasm adjacent to the inferior labial artery? Because the distribution was inferior labial artery. If it was distal, you'd expect just one focus to be ischemic rather than that whole area. My take on it would be the vessel was in vasospasm, and I just dissolved in that area any stray filler that might have been adjacent to the vessel, and the turbulence resolved in real time as well. The other question is, was it upset or spasming due to, choke vessels? And, you've probably heard of choke vessels where there's some ischemia or an occlusion, and the vessel proximal to that is trying to prevent any more filler or damage going beyond that point. These are questions I don't think we still have answers to yet. It's still new.
No, well, I mean, if I'm comparing your ability to see what's going on underneath with what you see as a clinician, which is something that reacts way slower than what you can see going on underneath the skin. You just see the skin. When I've dealt with vascular occlusions, it's you're 45 minutes, an hour and a half into the reversal, and suddenly you see a little bit of capillary refill coming back. Whereas you'll be able to see the blood flow immediately improve if it's going to improve.
And that's when you can stop and then review them the next day and just keep reviewing them every day.
Yeah, so that's tremendously powerful. Are you managing to see these occlusions? How long? Because obviously one of the biggest problems if you get involved with complications is by the time the patient gets to you, it's quite late on. Have you seen any, like what stage do you tend to see these patients? And
some of these referrals are coming relatively subacute within a few days. Or within a day or two, but often what happens is the injectors at this stage are more comfortable with just dissolving the whole thing, and they do multiple dissolves every day. And I think the future of acute occlusions with ultrasound is more precise. It causes less damage. You know how much dissolving people have to do with serious occlusions, especially when you have distal facial artery and angular artery. They're doing 1,500 units every few hours, which is huge volumes.
Yeah. So the background thesis is this is overkill if you can be accurate and if you can see what's going on.
Absolutely.
Yeah, really interesting.
It makes a huge difference to the client, makes a huge difference to the injector as well. You feel a lot more comfortable. And when you can confirm that the vessel is back under control, you can just say, all right, well, I'll rest easy and sleep tonight, and then I'll see you tomorrow.
Yeah. And that's super reassuring as well, because we're relying on just clinical, what you can see, but you're able to see the blood flow, which means you can send them home and not stay up all night worrying about them.
Exactly.
Yeah, that would be amazing to have that capability. So apart from vascular occlusions, how is it helpful in other complications? Are you dealing with nodules, lumps and bumps?
Absolutely. So what I'm doing is a pathway that I've created. Maybe I should name it the master pathway or something. I don't know.
Great
so what
name.
I do is I start with an MRI, and the majority of the cases I get passed on to tertiary referrals are long-standing filler. So the question is, Puffy hasn't had an injection for over 2 years, sometimes up to 12 years, and I'll show you a case. I'll share screen. They come to see me, and what I do is get a referral for the MRI, use the technique with the right sequences, find where all the filler is, and then I get the ultrasound scanner to confirm where it is and where it's bothering them. Often people wake up, as you know, they wake up with this edema, and superficial SOOF I find is quite a common problem. I just confirm it with the ultrasound scanner and do focused injections, and I'm trying to decrease the dose as time goes on from, I was doing anywhere between 100 units to a few hundred. Now I'm dropping down to 15 units, finding that little blob under ultrasound that I've confirmed on MRI, and just a fine squirt, and then getting them back as necessary.
Interesting. That's I'm getting more and more jealous the more we speak, because what I have often found myself saying is you can rely on the hyaluronidase to permeate through the tissues, and you don't have to. Therefore, it is a blunt instrument because it spreads so well. and you're able to then be super precise, and then you may save the patient a lot of money or yourself because you're not dissolving all the other stuff that's not causing a problem. So and this also means you're able to see filler, the differentiation between fat and filler with ultrasound as well as with MRI.
You can with ultrasound, but interestingly on MR, so MRI tells you it gives you good information on tissue density and contrast. It's called contrast resolution, what resolves between what's black and white, etc. Just to try to make it nice and simple. So we do fat sequences, for example, it saturates out the fat, it just becomes black. And what is filler going to be? It's going to be fluid signal, so it's going to be bright. So it's literally night and day on the MRI. On ultrasound, when it's a bit older, and this is a theory again, there's so many studies that I have to do. I've already got 2 or 3 on the roll, but there's more studies that are required. When it integrates, I'm with a sonographer, a close friend of mine as well, and sonographer that we work together, Goran, and he just shakes his head on particularly the established filler. And he says, I can't tell the difference. And I'll show you some MR images. You'll see, for example, cheeks. As it moves, my theory is it just sort of, with Langer's lines, it just tends to blend. So if you don't have those little boluses, it's very hard to see on ultrasound. But, you know, you can try your luck. If you can palpate or see a nodule, generally you can see it under ultrasound. And the ultrasound sometimes does find, so ultrasound has more resolution, so you can see very, very small things. But I believe that if it's clinically not obvious and it's been years and it's integrated, very difficult to see. So if I can't see it under ultrasound, I draw a map of the face. So, you know, I just have a look under MRI, ultrasound after the MR. I can't find it, and I go, well, okay, what I'm going to do is draw a map, get a picture of the face, and for example, superficial temples, there's some cheek filler that for some reason, you know, I've often seen it sort of track up here towards the temples, and I believe that there is some continuum, the fat pad there. I work out how many millimeters it is from the skin, how long it is, and how far it is from the orbital rim, and then I just do a linear thread, and it gets rid of it. Or for example, around the orbit, if I can't see it, I just measure from the orbital rim how deep it is and squirt it there, and usually I get a really good result.
Interesting. So you're also noticing something else, which is the places that filler tends to diffuse to over time through the patients that you're seeing. I realize I know why you want to do so many studies, because there's so many questions that would require
That's right.
a lot of data. For example, are these cases where the filler is spreading? Would it be possible to say it was a cannula case or a needle case? Like, is it more likely to diffuse in this area you've just spoken about if it was a cannula treatment, which is what popped into my mind? Any way of knowing?
It's so, and these are questions that need to be answered, but it's very difficult to know distinguish between cannula versus needle. And your theory regarding cannula, you sort of implied that cannula probably diffuses a bit more or spreads a bit more, in your opinion?
Yeah.
There's a few case studies, and one of them that's coming up in the publication, that was a cannula, 3 mil of a particular product. We're not allowed to mention products in Australia. And it diffused across. And if you don't mind, can I show you a picture?
Yes, I'd love to. While you get that out, I'm just going to, actually, my wife's will be listening. If she can close the door and put the heater on, I'm starting to freeze. Actually, she might be back in the house. Sure, we're in an outbuilding, and to keep the kids away. She's left the door open and I'm freezing. Okay, let's have a look.
So, can you see that?
Yes.
So I'll show you a diffusion case, and look, a lot of the time the questions we have is, oops, that says the product. Scroll down. Okay, so this one here, I don't know whether you can see that, if that resolves pretty well.
Yeah, I can see it really well.
So this is called a T1. That's the anatomic sequence where we look at the anatomy. You can see this black line. It doesn't show me an arrow, but you can see my little cursor going along here. There's a black line here and then a black line there. That's actually the SMAS. So it's actually quite well seen. And the injector's done relatively well. This is all artifact, ignore that. All this deep stuff, deep to the SMAS, is the cheek filler injection. So he's done a great job there, right? But see these? little
Yeah.
balls, that's right next to the sinuses. So it's diffused at the time of injection, though. This is an injection, and it's not the fault of the injector. I think when you're in the supraperiosteal plane and you don't have a zygoma there, it can track along the actual supraperiosteal plane next to the sinuses, which is very interesting. And that was at the time of injecting. An example more that I feel a bit more strongly about is the piriform. We all know about that old chestnut, don't we?
Yeah.
And interestingly, and I'll tell you what I'm actually doing prophylactically on patients. So this is going to be in the article as well. So this is the MRI. Again, you see this is fat. That's your nose. That's about above your the superior alveolar process. So that's your maxilla. They're your cheeks. So basically, this is your cheeks. That's a nice injection into the piriform. That's nice and deep. That's the right spot, right? However, see it's come across sort of laterally across there. And then here, it's kind of diffused across, and you'll have to believe me here, that's in the nasal labial fat pad. So this patient was injected 6 years prior. Products unknown. So 37-year-old, 1 mil of HA nasolabial folds, 6 years prior, and you can see there's still plenty of filler there.
So some of this is deep and some of it is superficial, and that wasn't necessarily how it was placed. Do you think it's kind of diffused to that place, or I suppose you won't know?
Diffused, or is it from movement from muscle? Again, the problem is I think studies need to be done whereby I or someone makes very succinct notes, and then we follow it up 6 months, 12 months, 1 year, and see what happens, and that'll give us a good answer.
Yeah. And this cuts the crux of what I think is so interesting about what you're doing, is because there is the story that you get told usually by the drug rep, which is, and certainly it's simpler for patients to understand as well, which is it's a bit more like your filler is, it's almost like filling up a glass of water. You fill it up and it gradually evaporates and then it's gone. But it stays roughly where you put it. Whereas what I'm seeing here is, firstly, it doesn't necessarily gradually evaporate. It might just diffuse and be there 7 years later. And it might also, it's not so much migration. It's not like a lump of it. It's just this diffusion and following the tracks within the anatomy and appearing in different places, but also changing a little bit in its nature. So I've seen in some of my patients that I've had for a very long time that you get this different presentation. I had an interesting one with a nose. It was 3 years after I treated her, and she just came back with this boggy feeling. She actually wanted a retreatment. She got used to it. And this is the interesting thing is, I don't think patients report a problem. I think they just think they've changed, they've got older, and they just need a bit more filler and they'll look a bit younger. And what you get to do with your skill set is actually show them that you've actually got filler there that's causing, it's not a fat pad. It's not edema because you haven't slept well. It's actually dermal filler that's just different from a treatment you might have had 7 years ago that you've forgotten about, which is really a really interesting, different way of thinking about it.
It certainly changes our mindset and how we manage patients, because unfortunately, supraperiosteal plane doesn't mean it's not going to move with the subcutaneous fat and skin laxity and bone atrophy and all the collagen and all the usual things that we talk about. So effectively, some areas may move with gravity. For example, cheeks, I believe. It makes sense that if it dissolved after 2 years, we wouldn't have to worry. We wouldn't have to manage it. But the problem is if it does stick around, that's why you get this heaviness. So the example I wanted to show you that we spoke about before is the orbit, and this is a post-septal complication, which I'll be publishing as well on a separate occasion. There's your globe. You can see that nicely. This is your orbital septum, and unfortunately at the time of injection, it's gone into the post-septal orbit, and she ended up with quite significant puffiness afterwards. So I did my pathway. I got an ultrasound scanner, and as you can see, there's your before on the left with that blob underneath the globe, and there's your after.
So you've dropped a bit of hyaluronidase in behind the orbital septum.
Yes, under ultrasound guidance, of course, so I don't hit the globe.
Wow.
So I was very close to the globe.
Yeah, that's a really interesting case, and it's something certainly you pick up when you train people, is that millimeters really matter in that area, and in particularly older people, they often lose some of that bony structure, and where you might expect to find periosteum, you can just pop through and find yourself on the other side. I've never seen a case like that that I've known about, but I have heard that if you do get filler behind the septum, that it basically persists for years. You know, and this makes sense with what you're saying as well, that there is no, if you're getting a side effect from that, really the only way you could have it treated, I don't know how well hyaluronidase would permeate through the septum, but basically you need a radiologist to place something very accurately there to dissolve it.
You'd need an oculoplastic surgeon otherwise to do, a blepharoplasty, or, and open the orbital septum to get it out, which is quite traumatic for the patient. So, and I've actually got 3 cases that I'm going to be doing a case series on. There's another one.
Wow.
She had an injection, 64-year-old female, 12 years ago. Product unknown, of course, and I wouldn't tell you the product anyway. And puffiness after the injection for about 1 month, she literally said she had a black eye. And she said that she saw multiple injectors and had been everywhere. And then she goes, I eventually found you. So she was delivered to me, and we did an MR. And again, I didn't do a follow-up MR on her because clinically it did resolve. But the management of these kind of cases, particularly in the tear troughs, are very tricky, because it's very easy, as you said, with the diffusion of hyaluronidase, you can actually dissolve too much for their liking and they want to be refilled. And that's the tricky part with this stuff, Tim.
Yeah, but 12 years, that's way off what the product would say. That's really incredible. And there, just on that note as well, I've certainly seen many times when clinicians have basically accused patients of having treatments elsewhere because it's not gone yet, and particularly lips. Maybe we'll touch on. I don't know if you've got any lip studies. I was looking at one of your images showed this what looked like to me like a diffusion up into the lip envelope, so it was away from the vermilion. And this is where you get that kind of over projected look. In fact, you see it. It's why I used Jar Jar Binks on one of the ads for this, because it's this elongation that you can occur. Yeah, great image right there.
So my theory is that over a period of time, and I'm wondering whether the capsule of the red lip is limited in terms of the volume it can take, or whether is it the orbic that's contracting constantly, that's slowly squeezing it above your vermilion border, superficial to the orbicularis oris. So we see this clinically all the time, Tim. I see it constantly. And what I do, which everyone can probably consider, is prophylactically, without imaging, I run my protocol is about 30 units here, 30 units there. The patients, I don't know whether you notice this, but patients are petrified of losing their lip filler. Mm-hmm. Petrified. And I haven't lost any lip filler above the lip yet. When I do a prophylactic, a number of linear threads above the lip, just above the vermilion border, and superficial. You don't need to go deep, because it's not going to go into orbic after they've injected it. And it comes up pretty well.
So this is hyaluronidase, 30 units each side at the point of retreatment. So you've had your first treatment and they come back, 6 months, a year later, and you see something
clinically.
From
other clinics. They're not
from other clinics. Okay.
This is the problem. You can't. It's very difficult. I'm trying to think whether one of my clients have come back with that issue, but I haven't had one yet. Maybe I'm injecting too little, or not sure. So I suspect the psychology for many injectors listening to this is when you see your client come back a year later and you don't like what you see, you feel a bit guilty. And sometimes it's like, I just don't want to acknowledge that, and we'll see what they say. The patient has got used to it in the meantime, many times, not always, but they quite often are happily just coming to have their lips retreated, because they see their faces in components, and what they're looking at is the red part of their lip and wanting more of that. And what they haven't noticed is the white part of the lip is now starting to project outwards, and you're getting this beak. And you need a clinician who's built into the first consultation that this is a possible outcome, for it to feel okay to then tell them that last treatment I've done is now
you now need a little bit of a taking out to create a beautiful result. And this is why I'm so interested in this whole topic, is we actually need to tell patients about this right at the beginning, so that you are free to then adjust for it later on without feeling like you're responsible for the cost of this and all those things that will stop clinicians basically making sure you get beautiful results. Because it does, sometimes patients they'll say it's bad injection, and it's not bad injection. This is just the nature of the products, and in some people. So yeah, it's really worth thinking about this whole filler life that happens after the treatment. I would say, I don't know if you're obviously dealing with a cohort of people who are having problems, and some people it won't happen. You will break down filler quickly and they'll disappear, right, presumably. Have you ever?
Look, my cohort so far is very interesting. I've got now 12 to 13, and I'm going to have a prospective and a retrospective study of 50 patients. Every patient, or of those 12 patients, they had not had an injection or any dermal filler for 2 years or more. That's the selection criteria that I had, and they all had plenty in there. So there was still plenty of evidence that there was, only one of them had a small amount of residual filler, which would be what we expect. You'd expect tiny little specks maybe here and there, only one of them. The other 11 had quite reasonable volumes. And interestingly, I think it's multiple factors, including patient, product, and area. The location will be all different. All the locations will be different. I'll show you a nose. That is, I'll find out how many years old it is. I scanned this patient recently. 42-year-old, 2002, 0.7 nasolabial. She's had nasolabials a few times. The nose filler was done in 2012. Scanned in 2020 on Valentine's Day. And you can see that is quite a decent volume still in the nose there.
That's incredible. So is your instinct that the average patient is getting years out of this product? Or do you think is this just like 10% of people who are lasting for 7 years?
I haven't scanned a patient who's said they've had dermal filler, bar one, out of about 18 or 20 so far, that hasn't had a very reasonable volume of filler remaining. But the issue is, yes, I don't think they're getting good value for money, because they are initially, but it has to be managed later on. And I believe it's going to be a cycle that we have to get rid of it in the wrong places. So the nasolabial patient, for example, this is that same patient who had a number of nasolabials. This is another example. See, she's got under the cheeks. When were the cheeks done? They were done lid, cheek, 2008, 12 years. Not a huge volume, but still there. See the nasolabials here? See how it's all diffused and spread? And that was quite superficial. So I did an MR cognitive map, I call it. It's a cognitive map where I draw these areas, just as you can see. That's going to be nasolabial fat. See the arrow? That whole area is nasolabial fat. So leave it in the piriform. It's great. You've got many years out of that. That's great news. Just dissolve the nasolabial fat space. So I'm actually prophylactically dissolving a lot of patients, or intuitively going, well, you've had nasolabials, you've had cheeks, let's just dissolve the nasolabial fat area. And you're not going to believe this, the nasolabial folds actually flatten. Yeah, and they think it's just aging.
Yeah, well, this is a really powerful thing. I hope everyone listening just absorbs that for a second, is that you think you're treating an aging patient, whereas actually you're trying to treat a diffusing filler problem in certain cases. That's really quite a big shift in how we think about these things. And what you're also saying is you can be targeted with hyaluronidase, and you've had some success with small doses treating the aesthetic problem without dissolving all the rest of it. Now, I don't know if we can all do that without all the equipment you've got and the skills you've got, but it's a useful thing to know anyway.
But I have had patients that have come in, or patients done completely, I don't want to say blindly, but as radiologists we say blindly, where the nasolabials are quite heavy. I get a history, and it doesn't matter how many years ago they did have cheek filler or under eye filler, etc., and they might have had a piriform injection. I just have a feel and a look, it's probably not going to hurt to do a small dose of, say, 30 units in the nasolabial fat and just look at the result. And I've had a lot of success just doing that. And that's everything. That's something that everyone can do in their rooms.
Really, really, really interesting. Yeah, Miranda's got some questions. Yeah. Come a bit closer.
Go for it.
Use this microphone if you like. I can't actually see the questions, so Miranda's going to read them out for us.
So Miranda says, without the benefit of scans, what is the best way to establish what is happening for clients having problems? Do you find more filler remains in certain areas more than others?
So what can you do clinically? Yeah.
Yeah. So clinically, it depends on where they've been injected. So the simple ones, very straightforward ones, is the moustache we talked about, the lip diffusion. Clinically, you can see that protrusion side on. It can be quite obvious, and the patients don't realize. They go, oh, no, I think I've always been like that, and they've been building on it for years and years. It's not going to hurt to do the 30 units across here, 30 units across there. Get them back, have a look, and you'll be amazed at how that lovely scoop, the scoop of that top lip comes back. You know, that correct projection, not that projection from the top of the nose, or just, sorry, from below the nose. The other one, as I described a moment ago, is the nasolabial fat space. The cadaver studies and a lot of studies that we have read probably would refute this, because they say that it's not possible for it to cross spaces. But I'm finding different. Was it injected incorrectly in the first place? That's a possibility too. But what I still do is, if the nasolabial fat is getting a bit heavy, they've had a piriform or especially superficial nasolabial injections, it's going to diffuse maybe medially, but a lot of it's going to diffuse into the nasolabial fat space. Just do a dissolve along the nasolabial fat space and see what happens there.
Yeah, I can see why you've got studies coming out of your ears in terms of what you can do, because there's so many of these questions. I was just thinking as you're saying that you need an ultrasound guided first treatment and then a follow-up MRI to see about this diffusion question, because that's a really important question. You know, if they're saying on cadaver studies that it won't cross, but you're seeing something different.
That's right. I think that's another research project. And look, a lot of these tools that I use, it is research, but I think it's useful to try. I'm going to try to, as much as possible, translate that into practice, everyday practice. And I think the lip issue is very common. And the nasolabial fat, no one believes it, but I've seen it time and time again. And I've done it on multiple patients blindly, and they say this is amazing. Obviously, the case that you can see on the screen here, I just mapped it out. I didn't even I used the ultrasound scanner, but I couldn't see it. So all I did is superficially dissolve the nasolabial fat, and within 2 or 3 days, almost immediately, she said, "Oh, the nasolabial fat is softer and not as obvious." So amazing results.
This is also links to this connection between the dynamic and the long-term process. So that if you think about your face as a functioning, moving thing, it's going to cause diffusion in specific directions. And this sounds like one of those areas where the nasolabial fold might be, so the piriform injections might just be naturally inclined to shove filler basically slightly more superficially into the nasolabial fold.
Into nasolabial fat as well. So
Yeah.
I guess when you're smiling and you're moving like this, and you got the LP sand pulling everything up, is that eventually just squeezing it up towards the superficial nasolabial fat, and it tends to be superficial. But I've seen again some deep nasolabial fat cases too, and you can get them back and do a couple of deep injections and see what the results are. Particularly large volume histories. They have histories of this lady here. Here's an example, 55-year-old, hasn't had filler for over 2 years. She wanted to know whether she had any filler left. And you don't have to, you can be blind Freddy and you'll still see that, right? She wanted to know if there was any left.
Wow.
And it's pretty mind-boggling. And you see that arrow there, that's nasolabial fat. She's going to look very heavy. So you do a dissolve along there and she'll get a vast improvement straight away.
Did you do anything on that case?
No, she kind of just got an MR and wandered off.
Yeah. So she knew it was still there. That was the main thing.
Yeah. Oh, yeah. She got the report her GP got the report.
So let me ask a question from Beverly. Beverly says, well, you kind of already covered this, but there's an extra element. Should we advise patients this potential migration of fillers can happen, and should it be added to the consent forms?
Yeah, these are the practical bits.
These are the practical bits. So I actually have included it. Every one of my discussion, we're adding it to our list. I mean, our consent form has just become a multi-page, like, corporate takeover contract or something. And it does describe, and I do say to the clients that it's still controversial. We don't know exactly, but there is potential that this filler will remain for a long period of time. If it lasts over a longer period of time, we may have to do a dissolve. And I give them about a 2-year warranty. I think that's not unreasonable to say that, look, any issues with it, but thereafter, it obviously costs the injector time, etc. Thereafter, if we have to sort of do a prophylaxis or a dissolve just as, safeguarding against it still being there, then we have to do it. So I do, and I think I don't want to give this advice, it's still early days, but I think we can say, while this is controversial, filler may last a longer period of time, and dissolving in unwanted areas may be required.
Yeah, I think that makes perfect sense. And I will certainly be changing that. And I was just thinking as you were talking about this, I've tried sculpting during lockdown, and when you sculpt a face, you don't just add more and more and more and more to solve all your problems. There are points along the process where you have to take stuff away. And we are talking about a living, breathing, dynamic interaction between the product and the face, and it makes perfect sense that for a certain number of people, you're going to have to take stuff away on a regular basis in order to get beautiful results. And I think that's every patient should know that before they start, that it isn't just a one-way process.
Can I just say, as a layperson, I think if you said to me, if you were educating me that was potentially part of the process, I would think of you well. I wouldn't think it was a problem that you'd caused. I would think, oh, well, that's just part of the process. So maybe just a new way of talking about it.
Yeah, it's just a new idea to weave in. I don't think patients will mind, because there is a benefit too, which is if you like the result, a percentage of the time it's going to last longer than you expect. And that's good news.
So a question from Neelam. My question on Instagram was, can you scan and do this as a sonographer, or do you have to be a specialized radiologist?
No, sonographers can absolutely. I'm scanning it, and a sonographer is more than capable, and I think there are a few papers on this topic. And I guess from a sonographer's point of view, you're looking at basically, and this is jargon, so should understand, or he'd understand. It's like a hypoechoic blob. Like, it's not fluid. It's just they're just little blobs, and you can actually find it. In fact, I did the dissolve above the lip of a client who actually is a sonographer, and I asked her to send me some photos of her scanning herself. So she scanned herself to try to look for if there was any filler left, and it looked like most of it had gone. But she said, I'm not sure what I'm looking at, and it can be tricky once it's established. But absolutely, a sonographer can do this, and I'm hoping that there's going to be more interest for radiologists. I did find that radiologists were just not interested, so that's fine. I'm happy to take the lead.
Yeah, I wouldn't worry too much. You're a trailblazer.
Well, everyone is going wild for this live. A colleague, Holly, was saying this is the best webinar she's ever seen. So Miranda asks, does it migrate because of technique or product choice, or are some people anatomically prone to this process?
Yes, and yes, I think.
Yes.
We can't give definitive answers yet. This is the problem. I can tell you on limited numbers, on a small cohort, that we can comfortably say a lot of these products do last. There's one client, one patient of note, a low G prime. I did see a low G prime that had almost completely dissolved within 6 months. You know, the really light ones that you can use in the lips? Mm-hmm. That's the only one that I've seen and I've personally injected that has faded away nicely. The rest of them tend to stick around. So I think a lot of it is related to technique if they're not your client. That's the issue. A lot of these MRs, only a few of the MRs are my clients that I've injected from the outset, but they've also had injections elsewhere. So the nasal labial diffusion, she was my client, but I did her lips, but her lips had dissolved, which is interesting. I think there's a lot related to technique. The diffusion issue, I think, is still hypothesis, and we can't say right now.
Okay.
In terms of the cheek and large volumes, if it lasts that long, logically, if your cheeks are starting to come down with gravity, etc., right, where is it going to go? It's going to travel inferiorly with your skin because it's not attached to the bone. Ideally, if we can get a filler that attaches to bone, I mean, you can use coral, I won't touch it, that would be fantastic because it just stays there. But I believe that with everything, if it's in the subcutaneous fat and it lasts more than 6, 10, 12 years, then some of it is still going to travel down where you don't want it. And so that's why another thing I forgot to tell you about, so I've said here, nasal labial fat. I also do an OG line thread of Hylace, and that works out fantastic.
Right, so that's for this superficial diffusion of the cheek filler that's adding basically to the jowl, and you're thinking it's fat and it turns out to be old dermal filler.
That's right.
Wow. That is that's extremely practical thing to realize. I mean, and of course, if you've been practicing for a while, you'll know if you've treated someone's cheeks 3 years ago, just knowing that it's a possibility that they may have some filler diffusing. In fact, it sounds from what you're saying, it's actually a likelihood in many ways. That gives you just another way of getting a better result, which we're not thinking about very often. So useful to hear that.
Stara says, is ultrasound guided injections perhaps a way forward in the future with aesthetics, like some physios do for steroid injections?
Absolutely, 100%. I think that's the way forward. I think it's going to take some time. As I said, you don't learn your injectables in one day, do you? Some people might and think they can just go ahead and just start slamming faces, but it takes years and it takes technique. So my take on this is that it's important that people take it very seriously and practice on normal faces and look for vessels. What I'm concerned about is people are going on very short courses and the false sense of security would be concerning. Oh, there's no vessels there. Bang, let's go. Needle, needle, needle. You know what I mean? I think it's important not to have that false sense of security and maybe start, bit by bit, maybe focus on ultrasound mapping of certain areas first, keep your routine and just keep working on one specific area and then move on to the next area.
Yeah, I mean, I must say, even though I've done, I don't even know how many cadaver labs, you only get to see like one in detail. And there's this ability that you've got to see every patient if you want to. There's a massive consciousness raiser to what the reality of what anatomy is, Yeah. It's how much does an ultrasound machine cost, like that would do the job?
They are very expensive at the moment. If you're going to be smart about it, in Australia in particular, they're not worth much at all. A decommissioned, good quality scanner with the frequency probe you need, it's in megahertz, so it's a very, very, very high frequency. So sound is 1 kilohertz, right? Mega is thousands above. So you want to get at least an 18 or 16 to 18 megahertz, which is a high frequency probe. And often NHS and the public hospital system in Australia, in the US, they decommission them and you can actually tender for them. And that can be quite useful. And sometimes they only go for under 4 or 5 grand. And these are proper big machines with multiple probes. So, you can scan an abdomen while you're at it.
Mm-hmm.
I think that's the most practical, but the handheld ones for a few grand, they're not gonna give you the resolution that you need.
And do you need like a duplex and so a scan that you can see blood flow and which direction it's going, things like that?
Yep.
Yeah,
they all have it. The vascular ones, the ones that are good for musculoskeletal, they're the best ones. You don't want ones for abdomens and pelvic scans, etc. You want the ones that are used for mainly musculoskeletal studies. For we do a lot of tendons and elbows. I do injections all over, as you'd expect. those machines are the most tailored to that, or the vascular ones, and all of them have color. So you put the color on and you can see that turbulent vessel, for example, or you can find that vessel. But there's a lot of techniques that you have to learn. You know, if you push too hard, you squish the vessel down. You need to know the difference between an artery and a vein, of course.
I was wondering then on that, the fact that you can see blood flow. I'm sure we'll have more questions too, but how often? Because the model that I've had is, you know, the blood flows up the facial artery, you know, up your nose, and some of it comes out the supratrochlear artery and it supplies the forehead. But is it always flowing in that direction, or do you see cases where it's kind of flowing down the angular artery? Because there's no reason why necessarily you could have a case where the supratrochlear is almost dominant in terms of the direction of blood flow. Do you ever see blood flowing in surprising directions, or is it as the textbook says?
Unless you've got an AV fistula, which we saw a case of, it was very interesting. In someone's face, a lump came up and she had an artery and a vein communicating. No facial trauma or anything. That was amazing. That's one of the only cases I've ever seen. Generally speaking, no, the direction of flow is correct. It will go, you know, venous, the facial vein is a monster when you scan that. Oof. The facial artery is a bit smaller, but it can be quite big as it, you know, it comes out in front of the masseter. The direction of flow generally, the surprises are the extra vessels. You see vessels. Transverse facial artery is quite a big artery, and it just runs under the zygoma there. And very few of us have run into troubles, you know, there. And it's very bizarre why we haven't run into troubles there. But, you know, supraorbital, supratrochlear, yes, you do have different dominance, but a lot of these vessels are sub-millimeter. They're tiny. And that's probably this is the difficulty with ultrasound. They can be extremely tiny, and, you know, sub-millimeter is pretty small.
Can I ask a question from a lay perspective? One of the things that we all struggle with, I think, in aesthetics is when people say that the filler runs out too soon. So for people who are watching this now, clinicians who are watching this now, is there something that they can say, which is, I watched a webinar which showed that actually these things are lasting way longer than you think. And so no, Mrs. Jones, your filler, I can see from your before and after, you know, pictures that you still got it.
It's still there. Well, you know, I think as we've described, it's hard to tell which is which, but I think the degree of cross-linking, the G prime. So the low G prime, they're the very, very light ones. You know, the ones that we use superficially, etc. A few cases, and again, this is anecdotal, so I don't want to, you know, say that this is a firm finding, but it's early findings that the low G prime tend to resolve and dissolve on their own. And I think clinically, the clinicians, if they've got good photography, clinical photography, that's important, and clinically reviewing them, I think a lot of the time clients get used to the way they look. So, you know, a lot of the time it depends on the product. But for example, tear troughs, let's just say, you know, you've had tear troughs and you had a pretty decent high G prime product. There's no reason why it should not still be there. And I think it's the impression of the client, and they need to go back. I think going back to clinical imaging is extremely important, looking at their photos.
Yeah, absolutely. Studying them really carefully, because a lot of the stuff is subtle, and you need the 3 dimensions as well. Particularly the lips. Lips are a good example. Clients will see the pink part of their lip smaller. They won't necessarily notice that the white part is actually projecting outwards unless you look for it. And I know you don't want to talk about specific branded products, but have you noticed do you think there is a difference between products apart from the G prime? Would you I suppose that's quite hard to answer without actually saying which product, but are you more likely to have issues?
Specific company brands or specific technology? No, I think the G prime is the only thing that I can say that affects the dissolve and the natural dissolve. I've got some majors and they're doing the same thing.
The other interesting thing is
one specific brand or one specific type of cross-linking or product.
And this means, even because we talk a lot about, I know in the UK, I won't, because it might affect your fee, but, you know, some products are supposed to last longer than others. And then that's also been attributed to some complications that might be more frequent. But essentially what you're saying is there's existing product from even fillers that are meant to last 6 months, you're still seeing them years later. regardless of what the packet says. So that's a really
Absolutely.
interesting thing to absorb as well.
Does the
Here's
paper
a
actually say that?
very good question. Can I ask? Are you ready?
Yeah.
So Claire says, when patients decide that in the right time it's a time for a conventional facelift, does the presence of residual filler have a negative impact on the repositioning of the tissues or cause any difficulties or complications?
That's a good question.
It's a very good question. I think if someone's considering a facelift and the amount of investment that they're going through, and I'm not encouraging everyone to get an MR. It seems impractical. It seems a bit over the top. But in complex cases, in Australia, it's our clinic, and it's a research price, but still we're charging 280 Australian dollars. It's like 120 quid. It's not much. And 25 minutes, it's probably the best 25 minutes they'll spend in a scanner. And that would show any residual filler. And you could map it out. You don't need the ultrasound scanner. You can just see, okay, there's cheeks, there's chin, there's this, there's there. And then potentially the injector could dissolve it. I will put out a paper, which will be, not an official publication, but just a recommended template that is for injectors for MRI. So what will happen is the radiologist will hopefully I'm looking at Radiopedia, which is a public forum, and a lot of Melbourne guys are actually radiologists, actually run that forum. It'll have a format saying upper face, mid face, lower face, and it'll say how deep, right, left, and how much. And so that would guide the injector to say, like, for example, Tim, if I said to you that angle of mandible, moderate volume, filler, superficial to deep, you'll know what to do, right?
Yep.
So it gives you a cognitive map to tell you where it is, or nasal labial fat, 4 to 5 centimeters from the nose. It gives you at least some sort of a roadmap, and I think that would be very useful and a good investment before having a facelift, because then you'll get your best results, because you need to get rid of all of it.
Mm-hmm. Well, I looking still at the image of your case of the 55-year-old with all that product. If she was about to have surgery, I think that's highly relevant. What's going on in her face?
They can't cut it out. I mean, they can cut it out, but it's a lot of work, isn't it?
Mm.
It's not easy.
Okay. Any other questions
No.
on your side? Okay. So I just kind of thinking about these categories on which you're shifting our understanding. We've got this long-term behavior of filler. And that's shattering that existing model of you put it in and it gradually evaporates and we go back to how we were before. We've got thinking about diffusion and migration. So we're actually seeing product that might be with the movement of the face appearing in different places. And then there's an extra component which is this sort of shift in the quality of the product over the years. I was wondering if you can tell with how old the filler is by looking at it or how long it's been there. Do you ever see a case like... No, because I've certainly texturally wise, you get this kind of edematous filler. So I've used the case I was telling you about before. It was a relatively high G prime product that would have been quite hard for the nose, and then 3 years later it was boggy and soft. And obviously, it doesn't sound like you can see the difference because the water content's the main thing you're seeing, isn't it?
Yeah, absolutely. It just follows the sequence, the consistency of water, basically. And I think it might be worth, if you're interested, it's worth doing an entire session on orbits. I think orbits are very tricky. Highlasing the area and how long it tends to last. The SOOF, for some reason, especially the deep SOOF, it tends to stay. And I've seen a lot of cases where it just sticks around. Superficial SOOF, they're the cases that I see a lot of problems. And even the post-septal case, this one, that looks like deep SOOF. It's actually not too bad. And you can see her lips. She got refilled soon after that complication, not by me. Not the orbits, but the lips. And you could see her lips couldn't fit anymore, and it went all the way up there. But I think the orbits are a very tricky area, and I think a lot of the referrals I get are bogginess under the eye after many, many years. They wake up quite edematous. And I think it's the hydrophilic nature of hyaluronic acid. Part of that, and I read a recent article that said that when you degrade hyaluronic acid with Hyalase, apparently it attracts even more water. which causes potentially more problems when trying to dissolve an orbital area, a SOOF. So I think that's a whole other discussion.
Yeah, well, I'd love to have that with you. Maybe we can do another session on orbits. That'd be really cool to go in deep on that.
Karen's asking about skin boosters.
Skin boosters. Have you ever seen a skin booster on an MRI?
Not yet.
No.
Not yet.
I wonder. That'd be interesting. Probably harder to see, I would have thought,
That's
if there's a thinner layer. Yeah.
It's probably good news because maybe just you don't see them and they're gone. That would be pretty straightforward to test. Actually, you'd get how long are they supposed to last potentially?
Yeah.
I don't actually know.
So I'm excited to do some more with you. If you want to talk about orbits at some point, that would be really interesting to go in even deeper. I think we've taken on board a lot of stuff that should be changing people's practices. Yeah. So we've got this idea that you should be regularly using small amounts of hyalase, that you can be accurate with hyaluronidase. That's also really useful to know. The model of consult, treat, review, and repeat is broken. You have to then be questioning, taking some away. I think that's a really important thing to absorb, and that we need to change our first consultations to build this in. And feedback from at least one client in the room with me is that clients won't mind hearing this as long as they're informed. Super fascinating, useful stuff. I can't wait to see what else you produce. Because I'm just full of questions. I know you are too. So these other studies will be really great to hear about. And yeah, keep us informed. If you publish something and I miss it, I'll be sad. So like, message me.
No,
we'll put it out.
If the audience like to check out my website, they can sign up for it, and it's any updates or any publications. We don't do mail outs very often, but when the PRS article comes out, we'll do a blast out and it'll be on the website. It's called aestheticradiology.com.au.
That's great. We'll include that in an email we'll send out to everyone to let them know that's here. So aestheticradiology.com.au. Is that right?
Yes, and it's I'm actually chuffed that PRS has accepted it. It's peer reviewed, and as a solo author, I thought I had a long shot, but interestingly, radiology knocked it back straight up, and PRS were interested, and it's gotten over the line, which is great news. They're just checking for typographical errors, etc., or the usual clerical stuff, and hopefully I'll have a date.
Yeah, well, fantastic. I'm surprised. I suppose radiologists wouldn't see it in the same way, but I understand why PRS have accepted it, because this is so practically important and useful. It's going to change decision making and long-term patient care and outcomes. Really amazing what you're doing. So thank you once again for joining us, and hopefully we'll do it again on the orbit.
Thank you so much. Everyone is so grateful on the comments. Really, their minds have been blown, and they're incredibly grateful. Thank you for that.
Okay.
Excellent.
Thank you very much, Mobin. It's been a pleasure.
Cheers. We'll be in touch.
Okay. Bye-bye.
Ciao.